So now I'd like to just introduce Rick Essner.
Thank everybody for being here so early in the morning on a Saturday. It's nice of you to come spend time with us to learn a little bit, and also for hopefully we'll learn a little bit too. So as Omid said, that I'm going to be talking about the role of surgery, and kind of alluding back to Dr. Pirro, when I first started my career, really surgery was the mainstream of treatment for melanoma, and in fact there were very few drugs, and the drugs were relatively ineffective, and so we did lots of operations on people. Some were successful, some were not, but certainly hopefully we all learned. So the earliest stage of surgery for melanoma is the skin biopsy. So although anybody in this room probably would say these images are melanoma, the reality is that you have to biopsy these things, these skin lesions, in order to tell. So again, nobody can make a diagnosis of melanoma by just an observation. These were kind of the ABCDs that were originally kind of described for giving people an idea of what a melanoma should look like. My impression is not everybody makes black moles. Redheads tend to make red moles. Some melanomas don't make any pigment, but really probably the best way to determine if you have something of concern is E-evolution, that is a skin lesion that's changing in appearance. Does not mean it's cancer, but the evolution or change in appearance should guide somebody to do a biopsy. And the concept of biopsy is we often talk about shave biopsies as being potentially, say, not a good technique, but the idea being is you want to make sure that a dermatologist or family practice doctor removes as much of the skin lesion as possible in order to give the pathologist the best chance to make the diagnosis. So the treatment of melanoma, the primary is still surgery, and we're guided by a number of different studies that have looked at what we call margins of excision, and these margins are based upon the surgeon's measurements, and we just measure with a ruler. And the concept being is that it comes down to, you can see, let's see if I make this thing work. Maybe I can't. Okay, so basically it's based just upon the thickness of the melanoma. So the idea being is a thinner melanoma, less than a millimeter thick, which again, that was determined by a pathologist. We use these a centimeter margin and so on. And so the idea being is these margins have been well studied and well accepted in the medical literature. We often hear about Mohs surgery, and so Mohs, the concept being is that basically a dermatologist, usually it's a Mohs surgeon, will remove the vast majority of a skin lesion, and mostly it's for basal cell and squamous. And then the concept being is that you take layer by layer, and they evaluate these layers as they go. And this works really well for some skin cancers, but doesn't work well for melanoma. And so we really frown upon using Mohs technique. The problem is, the good idea is that it's potentially removed tissue without removing excessive tissue. So for instance, like on the face, where you want to limit the amount of tissue removed, you can limit it. But the ability to detect melanoma cells by what we call frozen section is really difficult. And so as I showed you before about these margins of excision, what are the margins of excision when you kind of just peel the layers one by one? So it makes it really difficult. So anyway, moving on to the concepts of metastases. So this is kind of a drawing of the skin. But what I'm trying to show you is that when melanoma spreads, we do believe it travels via what are called lymphatics. And these lymphatics, we have them everywhere in our body. We have thousands of lymph nodes. We have them in our armpit, in the groin, in our neck. And then there's an idea being, at least the model, the concept is there an interconnection between the lymphatics and the blood vessels. And so the idea being is how do these cancer cells really move? Do they go to lymphatics? Where do they connect to blood vessels? Because we do see some patients that actually, their melanoma may skip the lymph nodes and move on. And so this has led to this controversial, this was first described by a number of people 50 years ago. Dr. Morton, John Wayne talked about it. The idea being is that could the cancer cells travel from the skin to the lymph node? And if indeed that was the predominant case, then we could remove lymph nodes and very few of the patients would ever succumb or have problems related to spread of disease. And then there was the other argument that actually it's simultaneous, that these interconnections between the blood vessels and lymphatics suggest that the lymph nodes are just markers. That is, the idea being that if you can spread to lymph nodes and you can spread beyond, and so there's really no value of removing all your lymph nodes. So again, a number of studies were done. As you can see, there's the 80s and 90s, the concept of what we called elective lymph node dissection. That is, you would have a melanoma in your right arm, and we'd take all the lymph nodes out underneath your right armpit in order to try to see if we could catch the melanoma early. And all these studies suggested these are what we call the p-values, and so none of these p-values are significant. So the idea of removing your lymph nodes prophylactically was never proven to be useful, but there was still data to suggest that if you actually took out the cancer when it was small in volume in the lymph nodes, there was a potential benefit to your patient. So this was the idea of sentinel node, and I'm sure a lot of you in this room have heard about the sentinel node concept. Again, developed with the idea using that you could use a dye, and so happened to be blue in color. And this blue dye would be injected around your melanoma, and the blue dye would travel the same pathway as potentially your cancer, make its way to the connecting lymph node. So again, the idea is that you could remove just this lymph node and leave the rest of them behind, and so you would accomplish what elective lymph node dissection was, that is, evaluating the lymph nodes, yet you would not subject the patients to the risks and complications of having all the lymph nodes removed. So this was developed in the early 90s. It was widely accepted throughout the world and has quickly become the standard of treatment for melanoma because it tells us, at least from a very strong standpoint, of what happens to you. So if there's cancer in your lymph node, your chances of success are much less than if you don't have cancer in the lymph node. And in fact, from this is the MSLT1 trial that came out of John Wayne back in the 90s, but suggested there was clearly a difference. If you had cancer in the lymph node, your chance of success was not as good as if you didn't. And so this was the stratum used to kind of determine who got therapy in melanoma. And so back in the 2006, when sentinel node was clearly shown to be a useful technology, the question is if the first lymph node has melanoma in it, what do you do about the rest of the lymph nodes? And so what was determined that only about 10 to 30% of patients that have cancer in the first lymph node will have cancer in other lymph nodes. But at the time, the standard was to take out all the rest of the lymph nodes in order to try to determine, number one, who these patients are, but the thought being is if they had cancer in these lymph nodes, you wanted to remove them. And so this very busy slide was the study that, again, also came out of John Wayne in the mid-2000s. The concept being is that you could take patients with cancer in the lymph node versus cancer in the knot. These other ones would be evaluated by another technology, but I'll explain. But the idea being is that if you had cancer in the lymph node, you would either be randomized to what we call complete lymph node dissections, removal, the rest of the lymph nodes, or just following the lymph nodes clinically and using ultrasound. So this study, again, took about 10 years to happen, but it really became to fruition. Dr. Ferries published the paper last summer, which looked at, again, only patients that had cancer in the lymph node, and half the patients are randomized to observation, that is just examination and ultrasound of their lymph node basin versus dissection. And you don't have to be a scientist, but you can see these curves completely overlap. So the idea being is that there's probably not a benefit to routine removal of all your lymph nodes anymore. However, I'm going to move on to a caveat of that because this is a new data, and I'll show you what's happened with subsequent treatments. But again, this is where it now become controversial in the sense that there's probably no survival benefit of taking the rest of the lymph nodes out. They divided the patients up into what we call PCR positive. That is, there was a group of patients in the study who had only molecular biology analysis of their sentinel node. So conventionally, we look at it under a microscope, but this is the idea using a molecular biology technique, and these patients seemed to do the best, but again, there was no benefit of further surgery in these cases. And so, bringing you back to the slide, it's now, it's no longer the future, is complete, okay, whatever. Removal of the lymph nodes necessary, and the answer is probably not. And so, I will again show you kind of the caveat of all that in just a moment. I bring this to your attention because this is kind of the next step in the role of treatment. And so this is a whole body PET scan. Some of you may have had one. The concept of this imaging technology is they inject you with radioactive sugar, and so everything that takes up the radioactive sugar comes up black. So this is somebody's brain, this is the heart, but you can see all these different spots. This is the bladder, but you can see these are a number of different cancer areas, and obviously we would not consider surgery for somebody like this. But there's an example of a case. This is actually, again, on a PET scan. This is the heart because it takes up the radioactive sugar. But this is somebody that had melanoma in their intestines. This is the CAT scan showing the same thing. So they had isolated melanoma in the intestine. And so clearly the data suggests that this is somebody that you might consider for surgery. So the conventional logic with surgical resection was not indicated, as that I showed you in that first PET scan, where they have multiple sites of metastases, because patients typically will have widespread of disease. However, back in the 2000s, when we selected patients quite well and we became very good at it, you could see that, again, this is before the advent of modern treatments in the last 7 years, that we did pretty well with surgery, and we certainly did better than other treatments, which was conventionally the chemotherapy we had at the time, which was DTIC. And so not very happy about the outcomes, but again, there was certainly a role for surgery in our patients. And so we kind of came up with these algorithms of treatment. If we thought, for instance, the duration of likely survival was high, then surgery was considered. If they had limited number of sites of disease, again, you could consider surgery for removal of metastatic disease. They were in good shape, so if they were not in good shape, they wouldn't be considered. If there was a long interval between their original melanoma, and as Dr. Pirro said, we see patients up to 20 years later, and not everybody is in that group, but if they had a couple-year interval between their primary and their metastatic disease, then they would be considered for surgery. And then again, what was the role? Was it just palliation, that is removal of symptoms, or did we actually think that there was a benefit? And so all those things went into the algorithm of determining which patients should have surgery. This was the data that came out of John Wayne, but again, you can see overall the median survival, which is the halfway point, was only around 7.5 months for everybody with metastatic melanoma. So really quite poor, and again, this is early 2000s. So I wanted to kind of transition into kind of what's changed in all this, and I bring this to your attention because this is a melanoma on the foot. We call it acrolentiginous melanoma, and what has been determined is we have found a mutation. So this is a gene mutation that's found in the tumor, and it's actually what we call a targetable mutation. That is, if you have this mutation, there's actually some drugs available to target this. And so things have changed very rapidly in the last about 7 years, because, for instance, this group of melanomas can be treated, not the original tumors yet, but the metastases can be treated with drugs to this gene mutation called c-KIT. More commonly in melanoma, we see something called BRAF, and so about half of skin melanomas have a BRAF mutation, and then there's some other mutations that also, NRAS is another one that's very much less common. The mutations don't come together, so you either have this one or the c-KIT. You don't have them all together, but again, this is a targetable mutation, and now there's medicine for it, and the same as the NRAS. So these things, again, have changed our approach to melanoma and which patients should be operated on. There's a little company that has come about in the last few years. They call themselves Castle, and so they've come up with a gene test, and some of you may have had your melanoma tested through the Castle technique, but the idea being is they take your primary melanoma and they look at particular genes and they say, well, if you have the right gene profile, you have a very good outcome. And if you don't have the right gene profile, your chances of success are less. And so the idea being is, can we use this? And the difficulty with this test right now is, as I showed you those other genes, we actually have drugs for them. At this point, we don't have any drugs to try to change these patients to this group. So it's prognostic, but not useful in guiding therapy at this point. Probably what's been the most significant understanding of cancer biology probably in the last 10 years is this paper by Lawrence that came out in Nature in 2013. And what they did is they looked at a number of different tumors. So all these different cancers. There's thyroid cancer, there's breast, prostate, kidney, ovarian, and then all the way to the right is melanoma. And what this paper suggests is that they looked at tumors, and they found which tumors had the most gene disruption in them. And melanoma was number one. And so the concept being is that these tumors have probably the most disrupted DNA, and as a result of it, it might explain a number of different things that we have now learned. Number one is that they seem to be more responsive to immunotherapy when they have more mutations. The second is these mutations probably come from the sun as a source. Squamous cell skin cancer is up here somewhere. It's up pretty high too. But the idea being is that these tumors have lots of gene disruptions, which make them targetable for immunotherapy, which is one aspect of it. And the second is also may partly explain their unusual patterns of metastases that we see. But I think the overall most significant part of it is that pretty much all the cancers that we take care of all have a large number of gene mutations in them, and which suggests that all these tumors are potential targets for immunotherapy. And so some of the work that I've been associated is looking at, this is a gene clustering profile, and it looks at gene mutations and overexpression of genes. And so we found that there's a difference between the metastatic tumors and the primary tumors. And so when we looked at outcome of our patients, we found that if they had a certain profile, their tumors, they group did better than the other group did worse. And so the concept being is kind of fits in with the paper by Lawrence, that if you have more mutations, you probably will do worse. And so this has led us to the potential algorithm of treatment and the role of surgery. That is that we might look for, say, if you have a BRAF mutation or an NRAS mutation, which we talked about, you might just get the pills for BRAF or NRAS. If you don't have any mutations, you might just move on to immunotherapy. And if you have the right molecular profile of your tumor, you might end up having surgery. So this is all in evolution as we learn how to treat melanoma in this modern era. And then also what kind of plays into all this is that the role of immunotherapy has evolved. So as Dr. Pirro said, in 1995, the only thing that we had was interferon, and up until very recently, interferon was the drug of choice. This was kind of the schematic of how interferon worked. And so the reality of it is, I don't know if anybody in this room got interferon, but I can tell you that all my patients that ever got interferon, none of them liked it. It activates a number of different side effects, and it was very difficult to take. It was self-injectable shots, and so for many years, this was the drug that we had for melanoma. And I think until more recently, where we've become better equipped and understand the targets which are now become common drugs, Yervoy and Opdivo and Keytruda, have come out of this pathway of understanding what exactly the role of what we call the T cells. And so, again, there's been a huge understanding of the concept being is what we call dendritic cells, which are kind of like the Pac-Man cells, and they interact with T cells to try to educate them. And what we have learned that these particular markers are negative signals, and so now the drugs that target PD-1 and CTLA-4 release these negative signals, which allows your immune system to respond. So now, these drugs have been around again. The earliest was about 7 years ago. That was Yervoy, Keytruda, and Opdivo came around more recently. But in the fall of last year, there was 2 papers that came out which were quite significant, suggesting that immunotherapy actually was useful after surgery. And so whereas in the past all we had was interferon alpha, we now have immunotherapy drugs. And so this curve is looking at patients with disease confined to their lymph nodes. And so we have found that Opdivo is actually better than Yervoy. And so Opdivo has since been FDA approved for what we call adjuvant therapy. And then getting back to what I talked about at the lymph nodes, the difficulty with the study for us as surgeons is all these patients had all their lymph nodes removed. And so it brings a question of, do we have to take all their lymph nodes out in order to get the benefit of the immunotherapy? And again, Opdivo is better than Yervoy, and so Opdivo has become the drug of choice for patients that have either melanoma in their lymph nodes post-surgery or even in stage 4 melanoma. So again, it brings back the question, do you have to take out all the lymph nodes if you have cancer in the sentinel node? This is what they did in these 2 studies. There are more studies on the way which will hopefully further clarify that. And then certainly I talked a little bit about what we call the targeted therapy, and so the BRAF drugs. So you use a combination of BRAF drugs, and so there was a study that again came out in the fall of 2017 comparing BRAF, and we use its sister drug, a MEK inhibitor, and so against the placebo. So these are pills, easy to take, but if your tumor has a BRAF mutation and you have complete surgical resection of either stage 3 or stage 4 melanoma now, you're a candidate for getting BRAF MEK inhibition. So this is what we call relapse-free survival. This is the overall survival curve, but highly significant. You can see out to almost 6 years. So now the world has completely changed. We no longer use interferon alpha at all post-surgery. You're either considered for immunotherapy or BRAF MEK combo if your melanoma has a BRAF mutation. So again, completely changed how we deal with post-surgical treatment. As part of all this, we talked about, this is kind of a subgroup of melanoma, what we call in transit metastases. And the reason I'm talking about this today is because in the days gone by, this used to be only a surgical disease in a sense that we would try to excise these skin lesions. There was a number of different therapies that we had. BCG was one of them. We would inject it with interferon. But in more recent years, there's been development of truly active immunotherapy and FDA approval. And so the first drug to get FDA approved for this called in transit disease is a drug called Biologic. Its other name is Tvec. And the concept being is it was really quite an ingenious idea. They took a herpes virus, which is like a cold virus, and they modified it. And they knew that the cancer cells would take up the herpes virus preferentially. And so a normal cell won't take up this virus. But what they do is they take the virus, it's been modified, it's taken up into cancer cells. It's very easy to inject this thing right into the skin where the tumor cells are. And then they modified it by putting an active immunotherapy drug called GM-CSF in there. And so the concept being is that you inject tumor cells with this herpes virus that's, again, been modified so you won't get sick from it. It then will allow it to release its immunotherapy drug and allow tumor cells to be killed and attract your immune system. And so this was the original paper, came out in 2014, suggesting that if you injected Tvec or Imlogic into the tumor cells or environment, you could see responses. So about a quarter of the patients responded versus if you just injected the immunotherapy drug alone, the success was very low. So the FDA approved it, and so now this is in the armamentarium of both the surgeon and medical oncologist. A lot of times this is given by surgeons because they feel comfortable doing injections, but it's very simple to do. You just basically inject this drug into the tumors or just in the environment in the skin over a series of injections. And so now there's another similar kind of drug. This is what we call a Coxsackie virus. It's another cold virus that can be actually do the same kind of thing, that you can make it replicate in the cancer cells, causing it to burst and then attract the immune system. So this is in study. There's even a drug. So this is actually a dye. It's called rose bengal. It's been around for a long time. And the idea being is, again, similar ideas that you can actually inject this into the environment. This is really inexpensive, but there's a study going on looking at this drug as an injectable agent into the skin metastases. And so these are called waterfall plots, but the idea being is you can see this is a negative change in size of tumors. And so we use this in the oncology world, but it shows all those responses that you can actually get using this rose bengal, which has a nickname of PV10. And then finally, there's another technology called electroporation. Essentially is the same thing, injected into tumors, but except this you use electricity, and you basically you shock the tumors. Actually, you can use a number of different drugs but basically it creates a little pulse into the tumor cell environment, causes them to lyse, then allows the immune system to try to react to them. So my talk overall is about surgery, and I kind of alluded to the role of surgery in melanoma, but I think really the advances in surgery have been a number of things. Number one is that there's been true advances in anesthetic care. There's been true advances in understanding physiology of patients and ICU care. And then finally, the last is using robotics. And so although we don't use robotics at this point in the skin, it certainly has a number of roles. And so all these little arms are basically, you could use different instruments that have been designed and through these different arms. And so as we do laparoscopic surgery, we directly control these devices. This is all done by assistance of a computer, which gives you very fine movements and allows you to use these things almost as hands. So in this case, this robot has 4 different hands that you can do surgery. And so the first one that came about is by a company called Da Vinci or Intuitive. However, now there's a bunch of different ones coming out. And so the idea being in the world of surgery, there's going to be a lot of different robots that help us doing our surgery. In fact, this little robot. And so the idea being is that not only we will have robotic arms, but we'll have image-guided surgery, and again, improvements in anesthetic care and ICU care will improve the outcomes of our surgery. Along with that, there's been improvements in pain control, development of really better non-narcotic pain medicines, and we could talk all day about concepts of nutrition and exercise, peri and post-operative periods, excuse me, which may also improve the outcomes of our patients. And then finally, this is kind of my drawing of how melanoma surgery and care has evolved. So we started out with, I think it was a Model T. We could do surgery. We used to do huge margins from the primary tumors. We took all the lymph nodes out. We used to do very big and morbid operations. We learned with the Sentinel node technology that we could do finer surgery and have better outcomes. And then in around 2010, the targeted therapies, the BRAF, so this is like the Prius, the first evolution of our really better care. And then the immunotherapy, my analogy is that it's moved on to a better, like a Tesla, that is more slick, works a little bit better, a little bit higher quality. And then last year it was the Bugatti, was kind of the thing where we're at. However, the reality of it is in 2018, not only do we have to look at these treatments, but actually the reality for all of us, we have to look at cost. And so some of these drugs have become very expensive. And so from the medical world, it's not that we don't want patients to get the best of care. We actually want them to get care that works for them. So the idea being is personalized care. That is, what treatment works for you is really the goal of all of us, to subject patients to the best care and also to have the best outcomes. And so I call this the McLaren, because it's the best of all worlds. It's as fast as that, but not so expensive. So anyway, I appreciate everybody's attention, and thank you for being here today.